Welcome all of you to this live program, Orthopaedic Principles. Today, our guest of honor is Dr. Jamal Asiri from Hamilton, Canada. Dr. Asiri is a professor at McMaster University in Ontario, Canada. After completing his residency at the King Faisal University in Dammam, Saudi Arabia, Dr. Asiri joined the Orthopaedic residency program at McMaster University in 2008. After obtaining his FRCSC, he completed his clinical fellowships at the Hamilton General Hospital in complex trauma and foot and ankle surgery. He's also a Royal College clinician and educator at the AFC diploma program at McMaster University. In 2022, he enrolled in the Canadian Orthopaedic Association Emerging Leadership Program. He continues to be the fellowship director for foot and ankle at the Hamilton General Hospital and also the clinical teaching unit director. Dr. Asiri has several high-impact publications to his credit on his favorite specialty, foot and ankle. So today is my great honor to introduce you to Dr. Jamal Asiri from McMaster University, Canada. Over to you, Jamal.
Thanks, Dr. Goblin. It's an honor for me to join the program and be part of this wonderful series of lectures. And for the sake of time, I will start. And are we okay to leave the question to the end or interruption? I don't mind either or, so we can keep the questions at the end, Dr. Goblin, or you want me to just
we'll do that at the end.
All right. So I will talk today about Pilon fractures. And the first thing I'm going to Pilon history, it's first described in 1911 by Etienne Distot, who was a French radiologist, where Pilon in English is equivalent to Bestel in French. And as you see here with that picture, that the Bestel is a metaphor for the Lafond effect on the distal and the talus. And historically, it's well known that Pilon fracture has a high complication rate with early total care, for which it was managed conservatively from early to mid 1900s. Till Rodi Algor principle started in 1969, which we're going to talk about it. So, Pilon fracture classification. There are different classification systems, which I'm going to describe briefly here. First one, Rodi Algor classification in 1979. We describe it in three simple types. One is simple fracture, no minimal comminution, or displaced articular segment with a less metaphyseal fracture, or completely displaced articular segment with significant comminution. AO classification started around around 8 years later, when they talk about the extraarticular as a type A, partial articular as type B, and complete articular as type C. And with the increase in significance of comminution, and increase the time. We move into 2005 for topless classification, rely on the shape of the fracture in both coronal or sagittal. For example, coronal fractures subtype has a coronal split, posterior split, anterior split, or V-shaped split, or a Y-shaped split. Same thing for the sagittal, either sagittal split, or intra-articular vertical split, or a T-type split. With the advanced imaging, we start to see more classification depends on the CT scan, such as Leonenti, with a different type of classification, or different type of different subtypes based on the CT scan findings. Based on these different classifications, Dr. Q in 2020 put this article about what is the most reliable classification system to assess cerebral Lafond fracture. They found that Rodi Algor and AO classification system are the most reliable among those. We're going to move on to assessing a Lafond fracture, including neurovascular injuries and other parts of assessments. As we know that The profound fracture happened from a high energy, usually from a high energy axial load injury. So be aware of the associated injuries, such as spine fractures, hip fractures, tibio-plateau fractures. Look into associated vascular injury. Lipas, in his retrospective study, they did a CT angiogram for for profound fracture, for Pilon fracture, within 3 days, and they find a high rate of vascular injury, especially with the anterior tibial artery, up to 50% of these cases. We also need to look into the fracture blisters. What's fracture blisters? It's a representation of cleavage injuries that happen between the dermal and epidermal junction. Giordano, in 1995, subdivided these blisters into clear-filled blisters and blood-filled or hemorrhagic blisters. The clear-filled one associated with a rapid reepithelialization compared to the blood-filled, which is associated with increased complication rates, scarring, and delayed surgical interventions. There is no compelling evidence to support any method over another in treating these blisters preoperatively or postoperatively. But remember, do not operate through traumatized tissue as a local damage control strategy. We need to assess for unopened fractures. As we know, up to 20% profound fracture or Pilon fracture associated with open fracture. Does a surgical approach or the open wound affect that? Yes. More medial and anterior open fracture wound location were significantly associated with a deeper infection. Pilon fracture, as we talk about it, is most likely happen with the high energy injuries. Type 2 and 3. Type 3 results in the poorest outcome and the highest complication rate. And if you look at these complication rate, even from 80s, 90s, we're looking at the 40% complication infection, 37% complication, or up to 55% infection with Dylan. Couple of studies talk about what are the risk factors for deep infection on these Pilon fractures. They found that independent risk factors such as diabetes, smoking, and need for soft tissue coverage can increase the risk of infection. In general, having the severity of the soft tissue injury might dictate the treatment protocol, which was suggested by Watson in 2000. When you talk about shrink classification for closed fracture soft tissue injury, if it's a grade 0 to 1, which is minimal soft tissue injury, you can treat it with open reduction and fixation. But if you have beyond that one, with a deeper soft tissue injury, then you may proceed with the external fixation as an initial treatment plan. If we talk about treatment options, is the non-operative treatment has any indications? Might be, such as a non-displaced fracture pattern, severely debilitated patients, especially with diabetes and neurovascular and vascular bath patients, and patients at significant risk of wound healing complication or compromise. But the results of the operative treatment were superior to the results of the non-operative treatment, was shown by Dr. Bodal and his team since 1980. So let's talk about operative decision making. How can we proceed, or what's the questions that I need to answer to go ahead with the procedure, with the operative treatment? Should treatment be staged or done at all at once? Should an external fixator, which might be suggested by Dr. Watson, to be used? Should it be placed temporarily or used for definitive treatment? Should we fix the fibula acutely? or leave it alone. What kind of incision should be made? Medial, lateral, posterior, anterior? There's multiple surgical approaches. And which implant will maintain the reduction the best? So let's go through this one. I will try to answer these questions. Rudy and Algo in 1969, they proposed 4 principles in Pilon fracture fixation, and that's based on 84 consecutive Pilon fracture that treated with open reduction at fixation. First principle, restoration of the fibular length with a plating. Second, anatomical reconstruction of the articular surface of the tibia. Third, cancellous autograft for metaphyseal tibial defect and a plating of the anteromedial tibia to prevent varus. In their study, they found 74% good or excellent results at 4 years. Look at that, 75%, 74, 75%. 3/4 have a good results. Can we achieve that one? What's the secret in their good or excellent results? There's a couple of flaws in this because the timing of the surgery was acute. If we look back in their study, within 3 days. Other part is the mechanism. 70% of these cases that have been treated in this study were found to be a low energy associated with a less soft tissue damage. And only 6 cases has a high energy mechanism. Let's move on to the Halford in 1994, who suggested the stage management, where it started with a temporary spanning X-fix, stabilize and protect the soft tissue, restore the length and may reduce the articular fragment by principle of ligament taxis, and strict elevation, and then proceed with definitive fixation when the soft tissue settle, which is by seeing the healing of the skin blisters, which take around 7 to 21 days. This is stage method where reinforced by multiple studies, including Sirkin in his study in the 29 patient with a 12 days delay, 2 stages, and they have 1 infection. And by Patterson, the same year, where they delayed to around 24 patient in a 21 patient and has no infection. However, what they suggested is the delay surgery until soft tissue envelope gets better. Based on these two stages approaches, Dr. Wyatt and his team, Dr. Pierre Gay from British Columbia team, challenged that one, and they did a randomized control. They did a cohort study in their 95 patients, and they found only 6% had a deep infection with an acute fracture fixation within 24, maximum 48 hours. They showed no significant difference. Look at this. However, they were a very small sample, and it was a retrospective cohort data with a level 3 evidence, and note that they excluded local soft tissue factors such as gross contamination and the presence of hemorrhagic fracture blisters. So let's take the first message or lesson learned. Operating through trauma idea, an early primary open reduction fixation of Pilon fracture with significant associated soft tissue injury has been reported to have an unacceptably high rate of complication. So maybe a clinical judgment should dictate. For example, one of my patients a couple of years ago with this one, open profound fracture. I think for me at that time, just apply external fixator and give the soft tissue time to recover. We talk about external fixation. Spanning external fixator outside the zone of injury would allow soft tissue time to heal, allow planning for surgical approaches, and the CT scan may be done after the patient is placed in the traveling traction or external fixator. Dr. Nielsen asked this question: is it safe to prep the external fixator inside during second stage Pilon surgical treatment? It was a retrospective study, but they show comparable to previously reported infection rate, with an overall infection rate around 13% and superficial infection rate up to 11%. Then the other question happened, asked by Dr. Shah. If we're going to go for definitive plate or definitive plating, does these definitive plates overlapping provisional external fixator pin side, is the risk of infection get higher? Even though it's a retrospective comparison study, they found significantly increasing the risk of deep infection if you place your plate over the previously located pin side for external fixator, from 24% versus 10%. What about locking or low-tech plating, either locking or non-locking plates? This is a meta-analysis or systematic review for 27 studies comparing both locking plate and non-locking plate. The results showed locking a plate will reduce the odds of reoperation and malalignment after treatment of acute severe fracture, which kind of make part of the sense that because you have a lock screws to the plate, it will act as a fixed angle and maintain a raft to your, especially the articular segments. Note that this is set down in 2014. It was challenged by another study in 2015, when it actually randomized control study. And their study showed there is no significant difference between the lock and non-locking group for the ankle hand foot scores, even though it's kind of conflicting here. But looking deeply on these studies, that showed maybe subjected to a type 2 error, as indicated by the low incidence of reduction loss, which is a low, minimally displaced plafond fracture. Let's move on to the next question. Should we acutely fix the fibula, as suggested by Rodi and Algo? Okay. What support the plating the fibula? It established a length. It might help stabilize by providing lateral buttress and decrease the surgical time for the next visit. That's the proposal on the fixing the fibula. But what if you don't plate the fibula? If you don't plate the fibula, or people who suggested not to plate the fibula will say the surgical mistakes have to be corrected if the blade is wrong. Surgical approach is now more complex because you already determined your surgical incision. Alternator and his group did ask the question about, does the fibula need to be fixed in complex Pilon fractures? And this has been published in JOT in 2015, where it showed not a necessary step. And it's associated with a higher rate of plate removal if the fibula was fixed. Another study in JOT suggested that it is associated with a significant rate of complication, and good clinical results may be obtained without fixing the fibula. Christian Bastius suggested why we don't revisit the principles of Rodi and Algo, and they have their new principles as the following. Fibular fixation is not always the first stage, depending on the pattern and the complexity of the fracture. In the presence of severe intra-articular comminution, the quality of joint reduction can be sacrificed to prioritize stability and alignment. Bone grafting is reserved for cases of substantial metaphyseal bone loss and in general in a delayed stage, not acutely. And finally, not only does the medial column have to be stabilized, but all damaged pillars in the Pilon fracture. Let's move on to what do we need to do before we go ahead with the surgery, pre-op planning. CT scan can be very appropriate. It's most useful after initial close reduction or external fixation application. It helps to determine the surgical approaches, help determine the implants needed, and either to fix or fuse it, which we're going to talk about that. As we all remember, with a trace paper that we mark the fracture and plan it in using a pencil and paper, we moved into CT scan and now to a 3D and now to a 3D printer. That's all help with the pre-op planning. The concept defined by the Rudy and Al Gore were stated based on the studies carried out with the radiograph. But after the advent of the CT scan, in recent decades, we have better understanding of the morphology and pattern of fracture that will help us to determine the surgical approaches and what implants I need to use. Pilon fracture, a new classification and therapeutic strategies suggested by Dr. Tang. He described the 4-column theory in decision-making therapeutic strategies for Pilon fractures. So all these classification was talking about the distal tibia or the Pilon fracture classification. Dr. Tang add the fibula as the lateral column that need to be addressed also. We'll talk about some peels and surgical management. The timing of definitive open reduction fixation depends on the soft tissue. Surgical approaches of articular reduction and fixation is based on pre-op imaging and avoiding severe soft tissue injury. And as a common rule, buttress blade should be applied on the column of dominant displacement, which suggested by Dr. Watson in 2017, which means medial blade for varus, anterolateral blade for valgus or recurvatum or anterior impaction. As we see in this example, this is a distal Pilon fracture or Pilon fracture that been in varus. You need to put the blade medial side to overcome that varus deformity. We'll talk about the second bill here. Although the minimum skin interval between the incision is unknown and likely is variable, skin bridges of 6 to 7 centimeters to be appears to be safe in multiple studies, including Dr. Howell's study in 2008. Positioning, putting some radiodistal platform will help to elevate and prevent the overlap, especially when you get the lateral view. Having some bump under the symmetrical same side hip will help with the maintaining the rotation of the distal Pilon fracture during the reduction. Don't forget soft tissue. We talk about the 3 vertically oriented angiosomes that exist, supplying the overlying soft tissue envelope of the lower leg and ankle. Ideally, you want to be working in between the angiosomes area. Surgical approaches. As we know, there are multiple options, including anterior, anterolateral, medial, posteromedial, modified posteromedial, posterolateral, lateral. So which one is which? That's why we need to remember. Every column needs to be fixed. So fixation of medial column, which was in Rudy and Al Gore principles, is an independent fixation of the medial column with a buttress plate as the mainstay of fixation. Recently, many surgeons using the anterolateral lock-in plate. And in a study in 2018 in Injury Journal, they showed that new plate was found to be superior to the other in capturing all the fracture lines of the Pilon fractures. Recently, most of the surgeon will place the medial plate subcutaneously through a minimally invasive incision to buttress and correct the varus deformity. We'll have a little bit of a scan into about different approaches here. Intermediate approaches. Intermediate approach for the distal pilon fracture. It's classic approach using the overrectal fixation by the AO group. It maintains a cuff of extensor retinaculum on the tibia for repair the tough closure to stop any bolstering. The limitation of this approach is difficult to visualize the chapel fragment on the lateral side. There is a risk of implanted prominence and wound breakdown, and there is also a risk of bolstering of the tibialis anterior and increased tension of the skin closure, especially if you don't close the retinaculum. Move on to the Polar's approach, which is the anterolateral approach between the peroneal tendons or fibula and the anterior compartment, in line with the fourth metatarsal. It provides an excellent visualization of the articular surface to the medial shoulder. It avoids dissection of the avoiding dissection of the intermedial tibial face. And the impaction of the medial shoulder is difficult to reduce with this exposure. Femur fracture can be fixed through the same incision. We move on to the anterior approach between the tib band, EHL, and neovascular bundle. Couple of slides here. What we need to know about this, especially for the anterior impaction, you can reach it easily here. What we know about this one, we need to make sure that we have to do a meticulous soft tissue handling. We need to close the extensor retinaculum that prevent the bolstering of the anterior tendons and provide a good coverage for over the internal fixation and minimize tension of the skin for closure. Pitfalls for the anterior approach: avoid extensile exposure in high energy injuries with significant metaphyseal comminution and soft tissue injury. Avoid forceful retraction or leaving the subretina for a long time. And a poor or incomplete closure of the extensor retinaculum over the tibialis anterior results in bolstering and increase the risk of wound dehiscence and infection. Posteromedial, just between your FDL and neovascular bundle, can give you a nice access to the posterior aspect of the tibia, distal tibia, or the modified one between the neurovascular bundle and the FHL. That can give you more posterior exposure. And the last one is the posterolateral approach, just between the peroneal tendons and FHL, give you the posterolateral corner of the platform or pilon. I would advise everyone have a look at the Asst article in 2007 when he talked about the extensile approach. If you can see here, he utilized internally the anteromedial approach. With his skin incision, used more lateral incision up to the joint level and then curve down to the medial malleus to start or stop just below the medial malleus by 1 centimeter. That's the first skin incision. And this is the deep exposure. And that gives him a full exposure to medial and lateral fragments of the profound fracture. That's a couple of X-rays and a couple of pictures showing that approach. I just put this one as a reference, and he talked about some pitfalls and effect of this technique. Small unusual technique not commonly used called the fibular notch approach, when you have a complete disruption of the syndesmosis, where the distal fibula is unstable. You can mobilize it posteriorly and work through that by creating a notch into that, creating a window in the fibular notch to reduce, especially the central impaction. Once we finalized the exposure and we did the fixation, wound closure, there is randomized controlled trial that's been done for comparing the Algor Donati versus vertical mattress, and found that the Algor Donati suture technique, as been seen here in the schematic pictures, it improved the incision and perfusion compared with the vertical mattress, and hopefully decreased the soft tissue complication. We talk about specific Pilon fracture, which is anterior compaction. It's a retrospective study. In multiple cases, they found that with an anterior impaction, it's a bad outcome. It's associated with more advanced post-traumatic osteoarthritis and the greater anterior tear subluxation. But what if patient already healed with that impaction? There is a study done in China which suggested that you can do what we call the anterior distal tibial plafond plasty, where if you look in the intraop X-ray here, it's healed in impaction. They create they use an osteotome, creating a cut anterior to the anterior impaction. Then on C letter here, you can see they use an osteotome to correct that impaction, fill it with bone graft, and close that window. What about the bone defect? Various agents have been used in a smaller defect, less than 5 centimeters, including autologous bone grafting, fibular scarring graft, cancellous allograft, or DBM, or synthetic substitute, such as a calcium phosphate or calcium sulfate. What about in an open fracture and you have a bone defect? Debridement of non-viable bone may result in significant bone defect that is not amenable for filling agent. So options include masculine technique, acute shortening with distraction osteogenesis, bone transport, or vascularized bone graft, or composite osteocutaneous graft, such as a vascularized fibula as a second stage. Small notes about the acute shortening, non-articular osseous debridement in combination with the fibular shortening. So there is no plan for lengthening, it's just an acute shortening for both tibia and fibula. In patients who are poor candidate for complex soft tissue reconstruction, it will facilitate the closure of the traumatic wound and at the same time addresses the osseous defect, encouraging both osseous and soft tissue healing without complex reconstruction procedures. This can be performed by acute shortening and plating defect up to 3 to 4 centimeters. What about primary ankle arthrodesis for a significant complex plafond fracture? It's an option for severely commonly type C fracture, where there is a more than 50% of tibial plafond delamination on preoperative CT scan. That was proven in multiple studies, including Gallman and Zeal in 2014. And also in 2018, when they found the primary ankle arthrodesis has a lower rate of non-union and it's comparable functional outcome to an open reduction anterior fixation. And a kind of a new news there, we just started in collaboration with the Western University in Canada and McMaster University, running a randomized controlled trial between comparing a primary ankle arthrodesis with an open reduction fixation in a Pilon fracture, the study called Pilon, and we are already in the process of hiring new patients. What about total ankle replacement for osteoarthritis following Pilon fracture? So this is a patient that had the fixation, healed, and now they have post-traumatic arthritis. Patients with degenerative arthritis following a Pilon fracture showed improvement in pain, stiffness, and functional scores from preoperative to 1 year after surgery by doing the total ankle replacement. Similar patient-reported outcomes were observed between the groups with degenerative arthritis following Pilon fractures and other groups undergoing total ankle replacement for different reasons. Patient satisfaction survey results demonstrated overall satisfaction among all the groups in 2 years post-surgery, and the complication rate were distributed evenly among all the groups. So it is a good option, but you have to be wise in choosing your patients. I'll cover some clinic care points. Always plan your surgery based on CT study. It allows you an adequate understanding of the fracture that is not feasible only with radiograph. Fibular fixation is not recommended at the time of external fixation as a part of the first stage of stage of step management. If so, if you're really going to fix it in the first stage, it should be done or performed by the same surgeon or in consultation with the surgeon who will perform the final fixation as part of well-designed planning. At the time of the open reduction of the fixation, start fixation by the fibula only if you are sure to regain length, alignment, and rotation. In cases of much fibular comminution, it's sometimes better to start with the tibia. Always try to achieve an anatomical joint reduction, which is an element that improves the functional prognosis in multiple studies, unless soft tissue damage or comminution does not allow this to be possible. The use of bone grafting is not always necessary, particularly with the development of percutaneous technique that offer better soft tissue care. Not only must the medial column of the fracture be stabilized, but as suggested by Tang classification with a 4-column, but all that is compromised, all the columns, particularly the presence of the metaphyseal comminution, must be stabilized also. What we do for post-op protocol: apply a very well padded back slab, no movement until the bone is healed. Range of motion begins at about 2 or 3 weeks once the sutures and the wound heal. Physiotherapy starts at 2 weeks for motion. Most of us will do 25% weight bearing at 8 weeks, 50% at 10 weeks, and around 100% weight bearing at 12 weeks. 4 progressive factors, published in Injury Journal in 2015. Multiple factors, including inadequate reduction, which we talk about it, shouldn't be greater than 2 millimeters of joint incongruity. Divorce status means you don't have a family or social support. Older than 55 years, which is associated with medical health issues. Lower education level, which relate to the compliance of the patient, and type C fracture, versus comminuted fracture. As the outcome showed, 40% is not back to work, and 30% incidence of chronic pain, stiffness, and swelling. Other poor progressive factor is when the tibial plafond fractures associated with a concomitant syndesmotic injury has significant worse PROMIS score, which is the patient reported outcome, and has a more end-stage ankle reconstruction surgeries and also with more open fractures. Syndesmotic injuries in the setting of tibial plafond fractures portend worse patient outcome. Everybody talk about Vanquist and Bottom these days. This is a McMaster group who did the systematic review and meta-analysis that focused in the GOT and the effect of local antibiotic prophylaxis and post-operative deep infection in fracture surgery, including the Pilon fracture too. They found that the risk of deep infection was significantly reduced when local antibiotics were applied, and the beneficial effect was observed in open fracture but failed to reach statistically significant in closed fracture. Vanquist study done by Dr. O'Toole in 2000, published or actually presented in the OTA annual meeting in 2019, showed lower proportion of gram-positive bacteria in the treatment group, 55% compared to 76%, and less MSSA, 17% versus 42%, and the concomitant nosocomial infection is less infection, and as we expected, no important difference in the rate of MRSA or gram-negative bacilli infection. This study was published recently in JAMA Surgery in 2021, and with their conclusion finding in this randomized control trial, 980 patients, where the intra-wound vancomycin reduced deep surgical site infection rate was 3.4%, and a post-hoc analysis found that the effect was the result of reduction of a gram-positive infection mean. What about incision negative pressure bone therapy? This is another study comparing, it's actually a randomized control study showing a lower infection rate when you use an incision vac with a lower infection rate and lower dehiscence rate in a pilon fracture fixation. The last point about hyperbaric oxygen therapy. Perioperative supplemental oxygen can reduce the surgical site infection after open fixation of high-risk fracture. This is a randomized controlled trial where it showed the use of high concentration of FiO2 is safe. It shows a trend toward reduction of surgical site infection and no significant difference in total. We are already waiting for the oxygen study, which is a bigger study done by Dr. Otto. It's still ongoing, and we hope to see the results in the next year or year and a half. By this, I would like to thank you from Hamilton General Hospital and for your listening, and I'm happy to listen to any question and answer going through any question.
Thank you, Jamal, for this very much updated presentation. Excellent work that you do at Hamilton General. Jamal, can you hear me?
Yeah, can hear me, sorry.
You can hear me?
I can hear you.
Yeah. So Jamal, just a few questions from our side. One is about, you mentioned about bone grafting, right? So traditionally, the principles outlined by Rudy and Al Gore in 1969, they said, but bone grafting of cancellous defects. So, and later on, people moved away from bone grafting. And do you think there's a role for injectable bone graft substitutes? For example, calcium phosphate. Do you practice that?
I mean, as a principle, we will bone graft if there is no risk of infection or it's not an open fracture, as everybody know that, right? If we talk about the closed plafond fracture, after you fix it and you reduce the arterial segment and you end with significant metaphyseal defect, having up to 3 to 4 centimeters, it's still acceptable to use a cancellous bone chips as being supported by Rudy and Al Gore, or we use a calcium sulfate, calcium phosphate. If we extrapolate the evidence of using this bone substitute, such as calcium sulfate or calcium phosphate, from the studies done in a metaphyseal fracture, such as a plateau fracture, multiple studies done and showed it. Calcium phosphate will help in less subsidence of the fracture, especially at the intra-articular segment. We don't have a specific studies done comparing cancellous with bone substitute in a plafond fracture. I'm just extrapolating that evidence that's been done for the metaphyseal or some similar fracture or the periarticular fracture in the plateau, where they found that it's a higher success rate for using a substitute than the cancellous bone graft. But both options were acceptable. It depends on where you work and what's feasible to have.
And what about in Hamilton General? Do you use these? Calcium phosphate?
We use both. We have the pleasure, we have the advantage, we have the bone bank beside us. So we have actually cancellous bone allograft, cancellous bone chips that I can go for 5 cc up to 30 cc, even up to 60 cc, I can impact all that.
Great.
The tendency to use, I find it that most of us will use still cancellous bone chips, even though, as I said, the evidence in the blood of fracture supporting the calcium phosphate or sulfate as a bone substitute, but we still use the Kansas we use it because we can impact and fill that gap with a kind of an allograft, Kansas bone chips allograft. But again, we still sometimes use, especially as a smaller defect, I can inject 5 or 10 cc of calcium substitute.
Thank you, Jamal, for that. And Jamal, in your clinical practice, I mean, you mentioned about different approaches, anteromedial, anterolateral, posteromedial, posterolateral. What are your favorite surgical approaches? Of course, the CT scan dictates your approach. The major fragment dictates the approach. What have been your common approaches?
Most of my approaches we go is actually anterolateral, and I can make either a small separate medial or posteromedial. I try to make them really opposite to each other. So if I start with the anterolateral, because as we talk about, most of us will still use the anterolateral plate, trying to avoid all the bone complication on the medial side. We tend to move away from the medial side, even though this is the side that this is the surgical approach that will be described for a long time, supported by the AO, by Rodi Algo, by all of that, to go for the medial column to prevent the varus. Still, I can prevent the varus, even if I use an anterolateral approach to have an anterolateral plate that capture the anterior and the posterior fragment, and I can fix the fibers from the same incision. If I need to go medially, either I do small medial MEBU technique, slide the blade, or from the same incision, I slide the medial blade, reduce the fracture, slide the medial blade, and then small blade through the same incision, slide it, and make a percutaneous screw fixation. But if I'm gonna make an open wound, I go anterolateral and I go posteromedial or medial. That's one. Most recently, especially with the Asst technique, if it is really complex and I think I need to really capture all the, reduce most of it, if it's a big pieces, I will stick to the anterolateral and medial or posteromedial. If it is a significant comminution that I think I need to pay more attention to each fragment, articular fragment, and I need more exposure, I will use an Asst, the extend side approach. I've been using it for a couple of cases recently, at least the last 2 years, and actually, I'll be happy with all the wound. I had one superficial wound infection out of these, I think 13 or 14 cases. I used it for the last 2 years, and I'm being lucky using that approach. Meticulous soft tissue dissection, minimize the retraction or self-retainer on the soft tissue, making sure don't devascularize all the fragments, and I end with really a good outcome.
Thank you, Jamal, for that. And Jamal, have you thought about nailing a Pilon fracture? For example, if there's just a split of the articular surface, it's just a two-part articular split. Have you ever thought of putting a nail in? And it's kind of a pestle, like the typical mortar and pestle, the picture that you showed at the beginning. Put a nail in, put multiple screws at the bottom, and it acts like a pestle.
Done it multiple times. But we have to make sure, as you said, especially if the distal ankle area has a significant soft tissue swelling and minimal fracture side, like minimal displace or blisters through my front. If I have a blisters around my open surgical technique and the fracture is minimal or non-displaced, like I can do percutaneous fixation, I will fix the articular segment and then put a nail, especially if the fracture or the comminution is kind of a higher, allow me to put more also lock and screws from the tibia nail.
Great.
But especially, I mean, it's almost like not completely different from a plafond fracture with a spiral tibia fracture with a posterior mal fracture, or sometimes it's a plafond fracture with a bit of a spiral comminution or a bit higher extension to the fracture side.
Thank you, Jamal. Jamal, I think that's all the questions that we have for this session. Thank you for this very comprehensive presentation, and I'm sure I could host you once again in the future.
My pleasure, and really thank you for the invitation. Thank you for considering me a part of this. Really appreciate that.
Bye-bye.